Hi, I'm Stacy Thomas, and I'm going to present the pathology of CNS lymphoma using a case study. We have the case of a 50-year-old male who presented in October of 2018 to an outside hospital with progressive mood and personality changes, right-sided weakness, and right-sided tremors. His MRI was concerning at the time for acute disseminated encephalomyelitis. A lumbar puncture showed lymphocytic pleocytosis. However, no infectious process was identified, and serology for a number of autoantibodies was negative. At the time, he was treated with a 10-day course of prednisone. But a month later, he was brought to the HUP ED by family with worsening symptoms and altered mental status. Multiple enhancing lesions, as we can see here on the MRI, were noted, and a brain biopsy was performed. When pathologists look at a normal brain using H&E, what they see is a lot of pink space and scattered purple nuclei. When looking at the H&E of this patient sample, it's easy to quickly see that the amount of pink space is greatly decreased and there's a lot more purple space, suggesting that it is abnormal. One way that neuropathologists are able to look at tissue is with a squash prep. And the squash prep of this patient's sample demonstrated further abnormalities, and those include thick vasculature that can be seen here. And there was also a perivascular accumulation of these blue cells on the squash prep. Additionally, nuclear crushing artifact was seen. And so that's these stringy lines of blue or purple seen here. And that's basically a result of lymphocyte nuclei being crushed as the squash prep is prepared. Additionally, on the squash prep, neurons were able to be seen, as well as scant mitoses. On frozen, the diagnosis was a malignant small round blue cell tumor favoring lymphoma. And so the differential diagnosis for a small blue cell tumor in the brain would be primary CNS lymphoma, secondary spread of a non-CNS lymphoma, metastatic disease of a small cell carcinoma from somewhere else in the body, or a small cell glial tumor. So this brain biopsy was then looked at further, and using fixed sections, more staining was done. And so the H&E stain sections demonstrated atypical lymphoid cells forming sheets. As you can see here, you again have not a lot of pink space and much more purple or blue space. However, on this image, you can also appreciate that there are occasional tingible body macrophages, and those are these areas of pink space that's popping through this sheet of blue cells. And so basically you have a macrophage nuclei surrounded by the pinkish cytoplasm, and those are your tingible body macrophages. Additionally, they were able to appreciate on these samples that atypical lymphoid cells are present, and they are medium to large for lymphoid cells with scant cytoplasm that is amphiphilic. And these cells often have eccentric nuclei, and you often are not able to see the nucleoli. And a perivascular pattern was seen in areas where the concentration was not as dense, where the small blue cells are really congregating around the vasculature. Immunohistochemical stains were used to further classify the cells. And so The atypical cells demonstrated enhanced proliferative and survival capacity because they were positive for Ki67, BCL2. Some were positive for c-Myc, and there was scant cyclin D1 positive cells. Ki67 is a common marker of proliferation, and BCL2 is an anti-apoptotic marker. Next, to determine the lineage of these small blue cells, a number of lineage marking immunohistochemical stains were used. And so c-Kit stains stem cells, CD3 and CD5 stain T cells, CD56 stains NK cells, and CD30 would stain Reed-Sternberg cells. And so you can appreciate that largely all of these were negative. However, when the tissues were stained for B cell markers like CD20, CD19, PAX5, and CD79, you can appreciate that the majority of the cells in this biopsy are staining for this B cell marker, suggesting that the atypical cells are of B cell lineage. To then further characterize these B cells, a number of other immunohistochemical stains were used to determine the lineage of B cells that these atypical cells originated from. And so the cells were CD10 positive. As you can see, compared to the positive control, it looks positive in the sample as well. BCL6 positive, MUM1 positive, CD138 negative, and Kappa and Lambda negative, suggesting that they are not of plasma cell origin. And so, in summary, the final diagnosis was B cell lymphoma, most compatible with diffuse large B cell lymphoma, not otherwise specified. And so, to summarize the immunohistochemical stains, basically they were positive for B cell markers and negative for markers of other lineages. And then just they determined that these were of germinal center subtype. And the way that that was determined was using the Hans criteria, which is a classification that has been used for a number of years in order to determine whether or not B cell lymphomas are of a germinal center origin or non-germinal center origin. And so this classification uses 3 different immunohistochemical stains. And so basically, if you have cells that are CD10 positive, then that automatically determines that you are of germinal center origin. And so the atypical cells in this case were CD10 positive, making it a germinal center lymphoma in this case. Additionally, FISH and sequencing studies were also sent on these biopsies, and mutations were noted in the MIghty88 gene and the CD79B gene, and both MIghty88 and CD79B mutations have been associated with primary CNS lymphoma in the past. There are multiple subtypes of primary CNS lymphoma. Most of them, almost 90%, are diffuse large B-cell lymphomas. And of diffuse large B-cell lymphomas, there are 3 subtypes. There's a germinal center subtype, the activated B-cell subtype, and the type 3 subtype, which is basically everything else. And then the other 10% of primary CNS lymphomas include T-cell lymphomas, Burkitt lymphoma, low-grade lymphoma, and Hodgkin's lymphoma. Classically, the histopathological features of primary CNS lymphoma include this thick vasculature on squash prep, a perivascular pattern also on squash prep, the nuclear crushing artifact that is seen. And then when you look at the fixed samples, you can see sheets of small blue cells. Again, you can see that perivascular pattern, and then you'll see that they stain positive for B cell markers like CD20. I mentioned that the Hans criteria is one way to determine whether or not primary CNS lymphoma is of the germinal center subtype or not, if it's a B cell lymphoma. However, the Hans criteria was developed a number of years ago in 2004. And in the years since its creation, there have been a number of revisions or attempts to make it more accurate. And so you can see a number of these detailed in this figure here. And in addition, there are now algorithms that utilize molecular data like next genome sequencing, qPCR, to try to encourage the criteria to keep up with the technology that is now being used in the lab. And I would like to note that this criteria was developed for diffuse large B-cell lymphoma, not specifically in the CNS. And so it's really unknown how these criteria actually fare in the setting of primary CNS lymphoma versus a nodal diffuse large B-cell lymphoma. And so here is an example of a algorithm that is used that incorporates some of the sequencing and genetic data into classifying these lymphomas. So here you can see that you're incorporating both the RNA, the DNA, and then you're still able to get those three subtypes that we already talked about: the germinal center, the activated B cell, and the otherwise unspecified type 3. Another quick teaching point that I wanted to bring up about this case is the impact of corticosteroids on the ability to get a histopathological diagnosis of primary CNS lymphoma. It's been said a number of times in pathology circles that steroids can melt lymphoma. And so corticosteroid treatment, or CST, can limit the ability of brain biopsies to be diagnostic of primary CNS lymphoma. And so actually in a study recently published, they saw that in patients treated with steroids, 10% of biopsies were non-diagnostic compared to only about 3.5% of biopsies in patients who were not treated with steroids. And this is because corticosteroids can cause cells to enter cell arrest or undergo apoptosis. They can cause tumors to shrink and can result in other morphological changes. And in addition, they can increase the population of reactive immune cells like macrophages and T cells, which can obscure the original pathology. And so here's just a few other cases where steroids did change the diagnosis of primary CNS lymphoma, or the ability to use the biopsy that was obtained to diagnose this. And so here we had, there was an 81-year-old man who presented with confusion and a large right frontal lobe mass. And he was treated with steroids, and then a biopsy was performed less than 48 hours after steroids were given. And the images that were obtained from this biopsy were seen here. And so you can appreciate that this looks very dissimilar to our original patient's biopsy samples, where you're no longer seeing sheets of small blue cells, and now you're seeing a lot more pink. And then you're also seeing less CD20 staining than you were previously. And again, here is another case where this is a 63-year-old man who presented with multiple enhancing, mostly periventricular solid lesions, and he had received steroids 8 days prior to biopsy. And again, this biopsy doesn't look too bad. You're not seeing sheets of small blue cells. You're seeing a lot of pink. And then when you're looking at the CD20 stain, you're not seeing diffuse CD20 positivity. And so this is giving you false hope that you're not seeing a lymphoma when the clinical picture was very suggestive that this patient had lymphoma. And here's another, just one last case where it's a 62-year-old man who presented with progressive memory decline and increasing headache, prompting an MRI, demonstrated a large enhancing temporal lobe mass suspected to represent a GBM. He received a 3-week course of Decadron to reduce the swelling. While on the steroids, his headache and cognitive symptoms significantly improved. And on the day of surgery, a repeat MRI demonstrated that the tumor had drastically shrunk. And so they changed the surgical plan to just do a biopsy. And so on that original biopsy, you can see that, you're having a lot of pink. You're not seeing sheets of small blue cells. You're not seeing hardly any CD20 positive cells, and you're seeing a lot of CD3 and CD68 positive cells representing T cells and macrophages, respectively. However, the patient eventually relapsed 3 months later, and his memory started declining again. So they got another MRI, and they showed new enhancing lesions, especially temporal lobe mass. And so they did a new biopsy, and that's shown in these bottom right figures here. And now you can see a H&E that is much less pink. You're now having sheets of small blue cells. You're having diffuse CD20 positivity, and much fewer CD3 positivity. And so this is just showing that in the absence of steroids, this patient was able to get a diagnostic biopsy demonstrating a CNS lymphoma. And so that is just something to keep in mind when treating patients who might have a primary CNS lymphoma. If you're looking for a tissue diagnosis, it may be better to do the biopsy and get that tissue diagnosis prior to giving steroids. But however, that must be done in the correct clinical context. And with that, I'd just like to thank you for your attention. And here are the references that I used in the preparation of this talk.